And when she did some asking, she discovered that there was no financing for research in cancer. And this frustrated her. As a matter of fact, she was so infuriated that she decided to do something about it. And as a result of her lobbying and advocating, she was able to galvanize the insurance community in America, which lobbied the US government to know what we now know as Cancer Moonshot, which is a federally funded initiative for breast cancer research. As we journey through the 1900s, we come into the 1950s, where Therese Lasser, a regular lady like you and me, discovered that she had a malignant lump in her breast. She went to her surgeon, and the surgeon said, as we often do in a sort of insensitive way, that the only thing that can be done is to remove her breast. Back then, surgery to remove breast cancer was extremely scarring, disfiguring. When she did her surgery, her physician had no time or maybe no answers for her. She had questions like, when, how can I resume sexual intimacy with my husband? How do I have a discussion with my children? What do I do with my swollen arm? And as a result of her unanswered questions, she galvanized a social group, which became what we now know the Reach to Recovery group. The media described this group as an army of ladies who went into hospitals offering social care to other ladies who were suffering from breast cancer. As a result of this ladies' advocacy, medicine was revolutionized into forming new ways to do surgical removal of malignant breast lumps without causing the arm to be massively swollen. As a result of this lady's advocacy work and the rest of her team, modern medicine has now incorporated physical therapy as being routine to rehabilitating our ladies who end up having lymphedema or swelling of the affected arm. And we fast forward to the 1990s, where this lady, just in her home, got concerned about funding breast cancer research. And so she started to make some little peach ribbon. Peach ribbons. Her name is Charlotte Harley. And in making these peach ribbons, it got the media's attention. Fast forward to 2024. We wear pink ribbons, and pink as a result of the work of advocacy groups, social support, because of the psychological impact of breast cancer. Now, why is this important? Why do we care about this in Jamaica? We care about this in the Caribbean because there is a pervasive social inertia in the Caribbean. What do I mean? Our patients, the societies that we live in, expect our health systems to have the answers. But that is not the history of Breast Cancer Awareness Month. And I'm going to bring it home a little closer. In 2018, the United Kingdom's government was convinced by a large body of evidence that now links loneliness, and social isolation to poor health and early death. And as a result of them being convinced by that scientific evidence, they formed a ministry of loneliness. There is a designated minister of loneliness sitting in the House of Commons for every parliamentary meeting, who is tasked with finding social solutions for people to care more about each other. In 2020, Barcelona in Spain, the municipal entity in Barcelona, the council, launched a municipal strategy against loneliness. In 2024, January, we have the governments of Japan, Morocco, Sweden, Kenya, Chile, and the US making this declaration. For too long, the power of social connection has been overlooked and undervalued in medicine and policy making. So in closing, I want to challenge my listening audience. It is not microplastics, obesity, poor lifestyle habits, alcohol, or smoking that is the #1 cause of premature death and suffering from breast cancer. It is loneliness. And so, specifically, I ask you to contemplate, can I become a champion? Can I become a champion for the next person I know with cancer, to mediate for their legal rights, as well as their caregivers' rights to get reasonable accommodations at the workplace? Can I advocate for whole person care to the healthcare team? And by whole person care, I mean advocate for physical therapy, referral to the nutritionist, referral to the community palliative care, or whomever you think needs to be a part of your healthcare team. Can I be an advocate for my neighbor? Can I partner in creatively finding solutions to change the discompassionate healthcare culture? Can I be a champion of advocacy to raise funds for research to improve treatments in breast cancer using the island's natural products? Can I become a champion, an advocacy champion for healthy eating initiatives like front of package labeling that the Heart Foundation is trying to get across to the nation? Can I champion that cause as a social advocate for my cancer sister who died? Lastly, can I champion the cause to learn how to better encourage someone with cancer empathetically? Can I champion that call to visit, call, pray with, cook for, accompany someone I know with cancer? Thank you.
Thank you, Dr. Green, for that edifying, thought-provoking presentation. We're now going to move on we're getting into the hardcore now, chemotherapy. Demystifying chemotherapy. And to do that is none other than our expert in this area, Dr. Tony Barnes, who is a consultant hematologist and medical oncologist at the Hope Institute of Jamaica. Give me the go ahead. Let's welcome her. Tell me when we are ready for her to go.
Good afternoon, everybody. My name is Tony Barnes. I'm a hematologist and medical oncologist, and today I want to talk a little bit about chemotherapy. Because it's Breast Cancer Awareness Month, I do want to talk about breast cancer in the context of chemotherapy as well. Just to give us a small, brief preview, cancer is a large group of diseases, not just one illness, and it can start in almost any organ of the body. There occurs a genetic change, some kind of strange mutation happens that makes the cells in a certain part of the body start to grow quickly and out of control. And that out of control growth is formed a tumor. When that tumor occurs in the breast tissue, either in the tissue that makes the milk or the tissue that brings the milk to the nipple, we usually call that breast cancer. So the treatment of breast cancer is in different parts, and it really depends on the type of breast cancer that you have, as well as the stage of that breast cancer. The stage of the breast cancer is basically how we determine how far gone it is. It is based on the size of the tumor that is there. It is based on whether or not there are lymph nodes involved, and it is also based whether or not there is spread of the cancer to another organ outside of the breast. Next slide. There are also different types of breast cancers that we have to be aware of. So there is hormone-positive breast cancer. So we usually say that those persons are the ones that have breast cancer that is responsive to the female hormones in the body, estrogen or progesterone. There's also a type of breast cancer called HER2 positive, and HER2 is a type of protein that is normally present in all of our cells, but in some types of breast cancer, the HER2 becomes more active. And then there's triple negative breast cancer that neither has progesterone, estrogen, nor HER2 present. Next slide. There are many treatment options for breast cancer, and in the next slide, I show that there are really three main categories. One being local control, so that is either surgical removal of a tumor or the entire breast, or getting radiation to the breast or to the underarm. There is systemic control, and by systemic, I mean the whole body system. Any medication that you give that affects all of the cells in the body is called systemic treatment. That includes chemotherapy, that includes hormone therapy, that includes immunotherapy, and that includes something called targeted therapy. And then supportive care is what we do when we are treating not necessarily the cancer itself, but the symptoms of the cancer, as well as possible side effects of the treatment. The next slide. Three main categories. Of the three main categories, I'm going to be focusing on chemotherapy today, but I will talk very briefly about what is hormone therapy, what is immunotherapy, and what is targeted therapy. Next slide. So what is chemotherapy? We hear a lot about it. It's kind of scary. It's something that we don't fully understand sometimes, but chemotherapy is a type of cancer treatment that uses special drugs or medications to kill cancer cells. That is its primary goal. And we call it systemic therapy because it works on the whole system. The medication travels through the whole bloodstream and affects the cancer cells that it encounters inside of the body. Next slide. The chemotherapy aims to target very quickly or rapidly dividing cancer cells, and the rapid division of cells is what makes a tumor form. Many healthy cells in the body also grow quickly, and those cells, like the hair on your head, the hair follicles, the cells in your digestive tract, the cells in your bone marrow that form your different blood counts, those also grow quickly. And because the chemotherapy unfortunately can't tell the difference between a fast-growing cancer cell, for example, and a fast-growing normal cell, you have, unfortunately, damage to the normal cells, and that's how you end up with some side effects. Next slide. There are other kinds of systemic therapy that I will briefly talk about. So immunotherapy is when we use the cells of the immune system and have those cells kind of do the work to damage the cancer cells. It works very well. We have it now available. It's something newer, something coming on stream that we use in addition to chemotherapy. But so far, it hasn't really taken the place of chemotherapy. It's more of an add-on. Hormone therapy, I spoke before about hormone-positive breast cancer, where the estrogen in the body spurs the breast cancer to grow, and the hormone therapy is able to block that estrogen or block the female hormones in the body and prevent them from making the breast cancer grow. Targeted therapy more refers to, I was speaking about HER2, which is another type of breast cancer, and it basically stops those proteins from making the breast cancer grow. The next slide. Why do we give chemotherapy? Well, the decision to give chemotherapy is based on different goals. Next slide. One is that we're trying to cure the cancer. That is our main goal. That is mostly what we want to try to do. Sometimes we give chemotherapy because we're trying to control the cancer. So for example, you have a large cancer. It is difficult to remove with surgery. It is too big, perhaps, to be adequately cut out. So we give chemotherapy to try to make it smaller so that the surgery can be done successfully. And then another reason we give chemotherapy is maybe not to cure the cancer, but if, for example, the cancer is growing and pressing on your windpipe, you're having difficulty breathing, we can give chemotherapy to make it smaller so that you can have breathing normally again. So it's not necessarily going to get rid of the cancer, but it can help to alleviate some of the ill effects. Next slide. So chemotherapy is a process, really. It is a journey. It is not a one and done treatment. Usually it is given at regular intervals, sometimes every 2 weeks, sometimes every 3 weeks, sometimes every 4 weeks, every 1 week. And it usually goes over a period of several months at a time. There are some people who require treatment for shorter times. There are some people who require treatment for longer times or even indefinitely. And it again comes back to what stage of cancer and what type of cancer you have. Next slide. So how do we give chemotherapy? There are several methods by which we can administer it. The most common method that we use is intravenous, meaning inside of your vein. And I have two pictures here. One with a drip that everybody knows. You're dehydrated, you black out, you go to the hospital, they put in a drip. And that's probably the most common way to give the chemotherapy. You can also get chemotherapy by something called a port, which is put in your chest. You can get chemotherapy orally, which is by pills, but that is not as common. And that really relates to very specific types of cancer. You can also get chemotherapy. Example, if you have skin cancer, there are some kinds of creams that we can use. And there are injections sometimes, like how you would get a vaccine, small injections of chemotherapy, or we can inject the tumor itself, depending on the type of cancer. Next slide. So I'll speak briefly about the side effects of treatment. Next slide. They vary really based on the type of medication we're going to use. Also the length of the treatment, how long you're going to be on it. Is it for several months, several weeks? It can vary also depending on the dose of treatment that we give you, and the dose is usually based on your weight and your height. And it also has to do with the individual factors. Are you a young person? Are you an old person? Do you have other illnesses? Do you have liver disease, kidney disease? Those things can also affect how the chemotherapy is going to affect your body. There are lots of different side effects of chemotherapy. Next slide. And I won't go into every single one. I just use this slide kind of as an illustration of how many different things, unfortunately, can go wrong because of the fact that the chemotherapy, unfortunately, doesn't only target cancer cells, but also affects normal cells in your body. So many different things like feeling tired or fatigue, nausea and vomiting if it affects your stomach and intestines. Hair loss is a very major one because of the fast-growing hair cells, but the hair usually grows back when the chemotherapy is complete. Things like loss of appetite, soreness of the mouth. Some people get diarrhea, other people get constipation. It is a very variable set of things that can happen, and it all depends on the type of medication we're using. It depends on you individually, and it depends on the type of cancer that you have as well. Next slide. So why are we bothering? Next slide. If there are so many side effects, why am I putting people through these things if I realize that it is so sometimes harmful? Well, there are benefits for chemotherapy. Next slide. And even though there are so many things that we can sometimes deem as harmful, we still offer chemotherapy to people who we think can benefit from it. So who are those people? One, if we think based on studies that have been done, based on the specific type of person that it is, the stage of the cancer and so on, that giving chemotherapy is going to lengthen their lifespan despite all of these side effects, then we will offer it. If we think that shrinking the tumor with chemotherapy will offer a more successful surgery, which will then hopefully allow the person to live longer and more comfortably, then we will offer it. If we are lowering the risk of the cancer spreading to other organs of the body, which will then cut down your lifespan, then we will offer it. If we are decreasing the side effects of the cancer, so we spoke about the windpipe before, if it's blocking it off, if the cancer is growing into a nerve and causing pain, and we think chemotherapy can shrink it and lessen the pain, then we will offer chemotherapy. If we can decrease the chance of the cancer coming back after it has been removed surgically, then we will offer chemotherapy. If we don't fulfill these things, if we don't feel like the chemotherapy is going to offer you a benefit based on the research that we have and the studies that are done, we won't offer it. So there are some people who have very early cancer for whom doing additional treatment like chemotherapy is not helpful. It's not going to make you live longer. We don't offer it. If your cancer is very advanced or you're very sick and we think the side effects might make things worse, then we also don't offer it. Next slide. So just really to cover some of the things that I think I get asked fairly often about chemotherapy. Next slide is things like, can I take my vitamins and supplements while I'm getting chemo? And the answer is yes, but you need to do everything kind of in conjunction with your doctor. It's very important that everything that you take outside of your regular medication, the doctor knows about. If it's a pressure pill, a sugar pill, the doctor needs to know about it. If you're taking vitamins, if you're taking an herbal remedy, if you're taking a bush tea, the doctor needs to know about it. Why? Because some of these supplements and medications can interact with chemotherapy or other cancer treatment. They can make side effects worse. They can make the chemotherapy less effective. An interesting example is that one of the treatments that I offer to people sometimes, green tea can make medication less effective. And green tea is something that people drink every day. So you wouldn't necessarily think that something like green tea is harmful, and it is not. But in the context of somebody getting chemotherapy, it's very important that the doctor knows so they can warn you. The doctor also has a responsibility to tell you that there are things that you should or should not be having, but anything that you're taking outside of the medication that the doctor prescribed, you need to let the doctor know. Next slide. Is chemotherapy painful? That's a very common question. And I think the most important thing to remember is because we're giving it in the vein most of the time, getting stuck in your skin, that kind of hurts. Getting an IV access or a needle poking you, that hurts. But it shouldn't be excruciating pain. It shouldn't be pain that is making you concerned. Sometimes chemotherapy can cause aches and pains, especially in the muscles and the joints. But it shouldn't be something that requires a lot of medical attention, and anything that causes you a lot of pain or discomfort, the doctor needs to know, because that could be a bad reaction. So it's not a normal response. It is not common to get pain from chemotherapy, but it can happen, so you should let your doctor know everything. Next slide. The last thing is, do I need to change my diet on treatment? And I won't speak too much about diet because we have a dietitian who's going to speak, but I would like to say that the diet that somebody has when they're getting treatment for cancer is different than the diet somebody has when they're trying to prevent cancer from happening or after they have completed treatment. So I spoke a little bit about how the blood counts can go low, the immune system can be affected by chemotherapy, and because of this, we try to eat a diet that is going to lessen our chances of things like infection. So for example, when you're eating a diet on chemotherapy, we have to make sure all of our vegetables are cooked, because if you have raw vegetables, sometimes there's soil on the outside, there are germs, and we don't wash our vegetables with soap and water when we're trying to eat salad. So because of that, there's no real way to kill the germs. You have to cook the vegetables. That's just one example. Fruits have to be peeled because we can't get rid of the germs on the surface. Another thing is people who like raw steak, people who like sushi, people who like moldy cheese, like blue cheese, all of those things have bacteria, fungi that your body is now not equipped to fight. So those really are the changes of diet for when you're on treatment, but off of treatment or trying to protect against cancer is a whole different ballgame, which I will let the nutritionist speak about. So I think those are my most common questions about chemotherapy, and I thank you very much for your attention, and I'm open to any questions that you might have.
So we'll take the questions at the end. But thank you. Thank you. Eye-opening, eh? Eye-opening. Eye-opening. Simply eye-opening. So we're going to move on. We're going to move on. So our next presentation, so we just spoke, so far we spoke about the psychosocial effects of breast cancer. That was done by Dr. Green. We spoke about chemotherapy and the myths and debunking chemotherapy. And you heard some of them. You heard that. You see, it's simple, but real truth. And that was done by Dr. Barnes. The next presentation will now be by Dr. Nadine Dietrich Badal. She's a consultant radiation oncologist, and she's also the head of the radiotherapy department at Kingston Public Hospital and the National Cancer Treatment Center at the St. Joseph Hospital. Who better to tell us about this than Dr. Badal, Dietrich Badal? She's going to be debunking radiation.
So good afternoon, church. Good afternoon to those online. I am Dr. Nadine Dietrich Badal, and I want to just thank you so much for the opportunity to be here to speak to you today on debunking myths on radiotherapy in breast cancer. Next slide. So as we look at this presentation, we'll be looking at the concept of radiotherapy, principles of radiotherapy, general indications of radiotherapy in breast cancer, common potential side effects of radiotherapy in breast cancer, and common myths about radiotherapy in breast cancer. Next slide. So what is radiotherapy? Radiotherapy is the use of ionizing radiation or high energy particles or waves such as X-rays, gamma rays, electron beams, protons to destroy cancer cells. The principles of radiotherapy are quite extensive, but just to give a general synopsis of what we do, the core of what we do is to give the highest dose possible to the target or the area of interest while respecting the normal tissues surrounding the area that we're targeting. And how do we accomplish damage to the cells? Now, within the cell is a structure that we call DNA, deoxyribonucleic acid. It is very important as it encodes all the genetic information for the function and development of the cell. And so radiotherapy acts against this by two routes. It has a direct route where it causes breaks in the DNA strand, and it also does it through an indirect route where it interacts with the water in the cell, producing free radicals, which then ultimately also cause damage in the DNA strand. Next slide. So there are various types of radiotherapy. Radiotherapy is quite a deep specialty, a subspecialty of oncology. And as you saw before by Dr. Tony Barnes, it's one of the chief modalities we use for local treatment of breast cancer. However, in the context of breast cancer, for the form of administration, radiotherapy can be used via external beam radiation therapy, or it can be via internal radiation therapy, or what we call brachytherapy. So external beam radiation is when a machine is rotating around the body and it is sending energy beams to the body, but it is never touching the body of the individual. Whilst with brachytherapy, radioactive sources are introduced directly into the tumor or in close proximity to it. Next slide, please. So there are general indications of radiotherapy in breast cancer. It must be noted that approximately 50% of the population of patients who are diagnosed with cancer at some point will require radiotherapy. This is no strange phenomenon, particularly with breast cancer. It can be primary, especially in patients who have undergone a breast conservative surgery. What do I mean when I say that? Persons who have taken out the actual tumor itself and tissues surrounding the tumor, or otherwise known as a lumpectomy, those patients have to receive radiotherapy with the surgery. It is a primary treatment. It can also be given as an adjuvant. What do I mean when I say that? You have persons who may have removed the entire breast, called a mastectomy, right? Those persons may actually still have residual disease there or have confirmed residual disease, and so radiotherapy is used to help to eliminate or sterilize that area. It can also be used palliatively as a form of symptom control. As Doc alluded to earlier, it can also be used palliatively. Why? We use it to help persons who are bleeding, and it's irretractable bleeding. The bleeding doesn't stop no matter what we do. And it can also be used for local control, particularly in persons who are no longer amenable to surgery. Next slide, please. So common potential side effects of radiotherapy in breast cancer. And these may include from skin changes, fatigue, changes in the feeling to the breast, changes in the size or the shape of the breast, lung complications, heart complications, or even swelling or what we know as lymphedema to the arm of the affected side. So what skin changes can we see? Many persons come into the clinic and the first thing they say to me, they send me for the burn-up treatment. I didn't go to school to learn to burn up persons. I went to school to learn to treat persons manipulating a property of radiation, known as radiotherapy. So what happens with the skin? The skin can become red, it can peel, it can burn, it can look like what we call a typical sunburn, right? It's otherwise termed medically as radiation dermatitis. There's also fatigue, a fatigue that despite sleeping, patients will tell you they don't feel any better with sleeping. And it occurs in approximately 70% of the women who undergo radiation. They also can say that they feel the breast feeling tender. There's a sticking or aching pain in the breast, and this may actually go up to or greater than a year in duration. They may also notice changes in the size of the breast or the shape of the breast, where the breast can become smaller than before or even larger, known as breast swelling. There are lung complications as well, known as radiation pneumonitis, because of inflammation of the cells within the lung, and persons then thereafter, they suffer difficulty breathing and chest pain. Heart complications are many, but the most common one known by literature is the pericarditis, which is inflammation of the pericardium or the cavity surrounding the heart, which helps the heart to beat effectively, and it causes chest pain, difficulty breathing as well. Lymphedema of the arm is just swelling of the arm, and it is particularly seen more frequent in women who undergo the removal of lymph nodes, right? Little glands under the armpits that help to drain the area. When they do the surgery and they do what we call an axillary lymph node dissection, then these persons tend to have a greater incidence compounded of lymphedema when they undergo radiation as well. Next slide, please. So common myths surrounding radiotherapy in breast cancer. A lot of persons say radiotherapy causes unbearable pain. This is not so. When you're on the machine, you do not feel anything. The machine rotates around you, and it's almost as if, I don't know if many of you have already undergone some form of imaging study like a CT. You don't feel anything in the moment. It's like taking a picture. But with time, as the dose accumulates at the level of the tissues, what you can begin to feel is soreness and tenderness to the area. So radiotherapy, in essence, on its own does not hurt. It is the damage that is suffered to the cell with time over time with the dose that eventually will cause tenderness and pain to the area. Radiotherapy can also cause you to become radioactive. Nonsense. Radiotherapy does not make you radioactive, particularly external beam radiotherapy. So yes, you have a type of radiotherapy where you can insert a radioactive source in the tissue and it can be permanent. We're not speaking about that type of radiotherapy. We are speaking about the external beam radiotherapy where the machine rotates around you so the beams enter and they penetrate and they exit. You do not become radioactive. So you can safely interact with your loved ones and your family without any fear of this. Radiotherapy causes hair loss all over the body. No, it does not. That can happen with chemotherapy, as our doctor alluded earlier, but radiotherapy is a local treatment. So therefore, if hair loss is suffered, it is particularly in the area where radiotherapy is administered. Radiotherapy always has severe side effects. Not so true. It depends on the individual. So while, yes, you will have persons who can suffer severe side effects, all of this is multifactorial and will depend on the type of administration of radiotherapy and the sensitivity of the individual in particular. Radiotherapy can be used as a last resort, can only be used as a last resort. So a lot of people will hear their doctor say, okay, we're going to send you for radiotherapy. And they say, oh my God, Lord God, I dead now. No, please, no. Radiotherapy has many indications. It is used in early breast cancer, in locally advanced breast cancer. Those are persons who now will have the disease not confined to the breast, but also within the lymph nodes or the little glands that help to drain the area. And also in persons who the disease has become disseminated or spread, what we know as metastasis. Next slide, please. So the other myths that are around there, radiotherapy is not effective for advanced cancer. Again, that's just repeating what I just said. In advanced cases, you have persons who, unfortunately, the disease is no longer able to be cut out. As Doc had alluded earlier, that's the purpose of the chemotherapy, to achieve an optimal surgery. However, there are times when even after having done chemotherapy, you do not get the response that you need. And so sometimes in very rare cases, radiotherapy has been evidenced to be effective as a neoadjuvant therapy, meaning before the definitive treatment, which is surgery, after having had chemotherapy. It can also be used with persons who, despite everything, you still will not be able to have surgery, but it can help to reduce symptom burden, such as pain or bleeding. So yes, radiotherapy can help. Radiotherapy harms surrounding organs severely. This is not so. Radiotherapy, because of the advent of sophistication in the technology that we use. So before we used to just do 2D, when I say 2D, I just mean two fields like we look at and we just use the bony structures, the landmarks in the body, and we used to just hit. We never knew what was getting how much, which organ was getting affected before. But now we have the facility through sophisticated technology where we can simulate the patient, called a CT simulation, and we can see the internal structures of the patient, and we can objectively measure and say, okay, the heart is going to get this much, the lung is going to get this much, and we can respect the tolerance level for these organs, and therefore side effects tend not to be as severe. Radiotherapy will compromise the immune system permanently. This is nonsense. Ultimate nonsense. Radiotherapy will not compromise your immune system permanently. Again, it is a local treatment, and it will only act where it is administered. Radiotherapy cannot be given to older adults. This is relative. It depends really on the performance status of the patient. So is this patient an up and about patient? Is this patient able to accommodate and tolerate the position they need to lie in to have the radiotherapy safely delivered? If not, then no, this person will not be an ideal candidate for radiotherapy. And the last thing which I have come across is once you receive radiotherapy, you cannot have it again. Now, before there was a fear that because of the tolerance of the organs that are nearing where we would want to treat would have received a certain dose, we would never want to think that we were going to go again and hit. But because radiotherapy has improved in terms of technology and sophistication, there are so many ways now that you can safely administer radiotherapy and have more targeted ways of doing so. And therefore, yes, once you comply with the criteria of a term called re-irradiation, where you take into account not just where was treated, but the time lapse between the last amount of treatment to the day when they represent with disease, it should not be less than 2 years, as well as you want to be sure that the disease is not disseminated or spread to any other area. Yes, radiotherapy can be used again. Next slide, please. So in essence, radiotherapy is a critical modality used in the treatment of breast cancer. And therefore, I believe in addressing these myths is important for informed decision making. It is a decision that you should always make with your doctor, because radiotherapy can be a safe and essential part of the management of breast cancer. I thank you.
Thank you. So I'm going to invite you all to write your questions in the chat, those who are online. At the end of these presentations, we're going to have a question and answer session where you ask the expert. We're going to have a roving mic in Sanctuary, and we are building up quite a crowd here in the Sanctuary. We're going to have a roving mic, and we're going to be taking your questions online as well. So as we move along, this is a very power-packed. Tell me something. Aren't you getting loads of information? It's designed to empower you. Together, we are stronger than cancer. And part of that strength is the information dissemination that you are getting to know how to set up yourself. And we're going to be doing that right through the evening, this evening. Our next presenter will be a very interesting topic. Very interesting topic. Our next presenter is Dr. Michelle Hamilton. Dr. Hamilton is a naturopathic physician, and she'll be talking about natural remedy and scientific approach. Let us welcome Dr. Michelle Hamilton to the podium.
Good afternoon, everyone. Okay, thank you, Dr. Cornwall, for setting me up like that. All right, so I know probably persons who are listening online and those who are in the sanctuary, you have all, different views. And I was so happy when Dr. Cornwall called me and told me about this forum and that she wanted to include natural remedy, natural medicine into it, because I think it is so important. And it's important for us to understand the purpose, the use, and how it really aligns with everything, especially as Seventh-day Adventist. Because for years, I've been quite concerned with the decisions that's been made and the comments where we keep putting them against each other. Yes, not understanding the information. So the two previous presentations, I was so happy to hear all of that. And now we're going to combine them in the right way, because you need to be informed to make wise decisions. So I'm going to start at the point of where we are as Seventh-day Adventists. We talk about the health message and the importance of our diet. Yes? We know that our diet is preventative as it relates to disease. But guess what? We don't factor health having just to do with just the food we eat and stuff. We tend to kind of limit it. So that's why I know that Dr. Green's presentation really hit it off the chart, because she talks about the psychosocial support. And that is the part we tend to leave out as it relates to illness. Now, we have a tendency also to just think that if something goes wrong and we start to eat right immediately, it fixes everything. but we're not looking at the spirituality, the emotional challenges that we have, all of those things. Yes? So, as it relates to cancer and the different forms of treatment and options that we have, as Adventists, again, we are known to indicate that we do not take anything that is harmful to the body. And of all that you have heard before, you're saying this is something that is harmful again. But I'm going to challenge you to think about this. What have you been doing outside of chemo, radiation, and all of this has been quite harmful to your body? We have been doing a lot of things, right? So we have to balance it. Yes? And we now have research and science that has given us a lot of information. So the first disclaimer is that nobody has the cure for cancer. We have done a lot of research as it relates to medication, drugs, natural medicine, all of that, and we can provide that science that shows you these are some of the things that we have known to be effective, that we have seen positive results in using, right? And this tells you that there are persons who are qualified to really advise you of what to do. So in terms of natural medicine, this is what I'm seeing in Jamaica. So everybody knows that I was trained overseas as a naturopathic physician. When I came back to Jamaica in 2016, I was told that there are so many naturopathic physicians here, are natural doctors that are in Jamaica. And I was excited, right? So I wanted to know some of these persons and connect with them. Well, eventually I found out after listening to a few and stuff that these individuals were not naturopathic physicians. And I knew this how. First of all, they'll tell you that they don't go to see an oncologist because what they give them is poison, and they don't do drugs and all of that. No, a physician is trained in medicine. We understand that in everything there are side effects and there are risks, right? So eventually, as I delve deeper, I realized that each one of us, and we would know some of these persons that would have had a health journey that would have led them to change their diet and their lifestyle, and they would have seen significant results. And we have studies that has proven that. When these persons would have gone through such an experience, they'll be no more convicted of sharing this message. And that's why we have the health message, right? Because Ellen G. White herself was sick, right? She wasn't a very healthy person. She had cardiovascular disease. There are a lot of things in her family. But then she learned about having a healthier diet and how it makes a difference. Now, a lot of these persons became so enthusiastic about it that they wanted to go out and help others. There is absolutely nothing wrong with that. Yes? But you have to understand that we live in a world where there are systems, there are regulations, there are standards, there are different code of ethics for practicing. So therefore, we have a field that's called medical missionaries, and as a result, these persons came under that banner. And in so doing, they were helping persons to have a healthy lifestyle and a healthy diet, and that was wonderful. However, somewhere along that way, some lines were crossed. And now, and I believe, it's just natural as human beings. Persons start to experience, feeling better, and they'll tell you all that would have happened to them. And they start to say, boy, you're a healer, you're a doctor, and they start to call individuals doctors. Until eventually they became known as Dr. X, Dr. J, Dr. Y. And once you hear that, persons would refer, or hearing these persons being mentioned or called that, would now start to seek their help and their support. And they would continue until they establish themselves and have these titles. And now when persons would go to the regular doctors and be diagnosed with cancer, and they're now in fear, they seek the help of these individuals who tell them, yes, I can help you. The natural medicine can heal it. And they'll put them on a diet of juices, and they'll put them on a fasting diet and all of these things. Again, we know that food is medicine. We're not discounting that, but we need to be informed and understand how to use it and who are the persons who are qualified to guide you to do so. So what I have seen so far are that these methods do not work in and of itself to cure anyone from cancer. And that is the truth. You can use all of these natural juices. You can do fasting. All of that has health benefits. We are not discounting that. But if you're diagnosed with a condition, whether it is cancer or any other condition, you do need to be under the care of a professional, a medical professional. So now let us look at what's a naturopathic doctor. A naturopathic doctor is trained in medicine just like a medical doctor, with the exception that instead of going covering medicine for the 4 years, we cover medicine and then we move on to natural medicine. So we're able to treat from both ends, but we only use natural medicine. So the knowledge that we have and the skills are pretty much used to pair natural medicine with conventional medicine to deal with the side effects of conventional medicine and to help the body to heal. But we fully understand drugs, we fully understand how they work in the body, but we also have the added knowledge of how to combine herbs with drugs, which a medical doctor would not have that training. We have the both sets combined, right? So how is that important as it relates to cancer and natural remedies? So first of all, natural remedies are the home remedies, like, for example, what your grandmother would say, okay, you soak some garlic in some honey and put it down, and you know, every time you feel your throat itchy or something, you take a spoon. That's natural medicine. We all have some little concoction at home, right? Natural medicine are unproven. That's one. And we advise that when you have these remedies, nothing is wrong if you're not on any other medication, but after 3 days, if you are taking it for any common ailment and you're not improving, you go and see a doctor. That's how natural medicines work, and that's what you're to do. Within 2 to 3 days, something is acute and you're using it and you're not seeing any improvements, you have a cold and you realize that, it's getting worse, it's changing color, go to a doctor. Some persons' immune system are more robust, so as soon as they, probably make some ginger tea, they'll get some relief and they will continue, right? And they know that, yes, I'm seeing a difference. Outside of that, you don't stay home for weeks and keep doing this and things are not improving, right? So those are natural remedies. As it relates to treating cancer using natural medicine, you would seek the aid of a naturopathic physician. Now, in Jamaica, currently, to the best of my knowledge, there were 4 of us here. One has gone back to the United States about 3 years ago. And there were 2 here before I came back. And in all now, there are 3 trained naturopathic physicians. We are all trained in the USA. And in the USA, a naturopathic physician works with an oncologist. If I have a cancer patient, we work with an oncologist. The treatments are paired with an oncologist. And as the Dr. Barnes had said before, that when you diagnose someone with cancer, it depends on the type of cancer and the person. The treatments are different. Now, the first thing someone should do when you're diagnosed, and we're going to use the breast cancer as an example, is to ask all the questions that you need to ask about learning about the cancer. Be informed. Ask the doctor, ask them to explain. And then when the recommended treatment is given to you, again, ask all the questions that you need to ask to ensure that you understand. If you are someone who seeks to find another option, which is natural medicine, right, then you also can consult with a naturopathic physician. If you start with a naturopathic physician, we are going to send you back to an oncologist because we want you to make an informed decision. So we are going to be telling you, okay, these are your options. And we will include chemotherapy based on the type of cancer to tell you, based on studies, based on what we know, we have seen proven results for this type of cancer with chemotherapy. So we can actually tell you that. Yes? And we can actually tell you, well, if it's combined, then this is the best option. So you first need to get all of that information, but you need to find the right source. Now, ultimately, it is your decision what you choose to do, right? But even, and I've seen this a lot of times, even when persons have all the information, they will still choose to say, I want to go the natural way. Yes? So when you hear that, right, I typically say you still need to be under the care of an oncologist, because at some point during your treatment, you are still going to need an oncologist, right? It is your ultimate decision, but you have to make an informed decision. Most oftentimes when persons show up with this idea in mind, they would have already made up their mind. They don't want to see an oncologist, and these are persons who are not very compliant anyway. So they will go away because they'll say, oh, I'm talking to them like a medical doctor, and I don't want to give natural medicine. No, I'm telling you the truth. I am trained to treat cancers with natural medicine, but at the same time, different forms of cancer requires different approaches. And a big part of it is the psychosocial. Yes, because for some persons, when they hear cancer, the big C, that alone is enough. No matter what you do for them, natural medicine, chemo, that alone is it. The psychosocial part of it is a huge factor. It's a huge factor. Now, over the years, in the US, we have different centers. So the Cancer Treatment Centers of America, which I think is now called Cities of Hope, if you go on their website, you will see that in all of the treatment centers, you have naturopathic doctors that work with oncologists. How do they work together? Okay, someone comes in and they've just been diagnosed with breast cancer, and the doctor would recommend doing a lumpectomy or a mastectomy. Yes? The first thing for a female is that I do not want to lose my breast. My husband will find me unattractive. I'm worried about my relationship. I'm worried about if they're not married, finding someone in the future. So most of it starts here, right? Doctor, yes, that's where it starts. And they go scared. And then they come now to see a naturopathic doctor because they want to see what they can do to save the breast. And realistically, it depends on the type of cancer and the stage. Most oftentimes, I always agree with the surgery. And that's the truth. Cancer is very dynamic and very hard to treat. Yes? So most often, it's always the surgery that will come first, and I will agree with it. Yes? Now, say the person would have had the surgery, and they have follow-up treatments in terms of whether it be radiation or chemo that's recommended. I notice in Jamaica, again, some persons will go and do the surgery, but they do not want to continue with the other treatments as well. Yes? Again, I say it's their choice, but how do we work with patients in terms of natural medicine? Now, I can give you the model again in terms of the US because it's not really done here per se, but natural medicine is used to counteract the side effects of chemotherapy. It is also used to also help the person to recover during chemotherapy in terms of dealing with some of the side effects and the symptoms that they'll actually feel. For example, with radiation therapy, if they have like nerve damage, other things. So natural medicine can help to reverse a lot of that. Also, during the treatment with chemotherapy, if at some point their immune system becomes too low, different things that will actually occur, then what will happen is that the patient will be taken off the chemo for a while, and that they'll now work with a naturopathic doctor to rebuild back the immune system, to also correct the damage to the liver, and that's what we are good at. Yes, so when they're taking the drugs for chemo and the liver becomes damaged, the immune system becomes low, within a few weeks, they're assigned to the naturopathic doctor. We build back the white blood cells. 2 to 4 weeks, white blood cells are back. Yes? So in terms of the combination, that is how it is used with chemotherapy, to deal with the side effects, to repair the organs, and help to deal with symptoms. Now, have individuals tried to use natural medicine alone for cancer? Yes, they have, but in only certain type of cancers that you would have seen that, and you'd have seen significant results. Yes? So breast cancer is a little bit more dynamic, but yes, some persons have and they have seen results. But again, these are studies that have been proven that, look, this can work. But even so, they're still under the care of an oncologist at all points of their treatment. Right? You cannot be without an oncologist. Right? Because what we understand is that, just as Dr. Barnes had said before, you can be on a chemo drug, and the person will be at home taking different things, your supplements, your herbs, all of this. It's very important, because whilst you are trying to, find a different treatment method, and you're saying you're doing this to support your body because it's healthy, you can actually be decreasing the effectiveness of the therapy by doing that. Hence, that is why you need someone who is trained to combine it. So individuals who are on supplements, they're generally taking off certain supplements when you're on chemo, because we do understand, based on the drug that you're taking, how it can actually work against it. We also know that there's some supplements that you can take because it will increase the effectiveness of the therapy, right? So you need to be informed. In regards to herbs, she mentioned green tea, EGCG, that's the extract that we use from it. And green tea has been very effective in causing apoptosis or killing cancer cells. But if you're on a particular drug, you cannot combine them together. Hence, a lot of persons will say, hey, it did not work, because they're not looking at the fact that they're drinking all of these green juices. They're doing the stuff at home and they say that's healthy, so it's the chemo that's not working. Your doctor needs to be informed of what you're actually taking. That's why it's important that you work with a physician who is trained, that will guide you to work with an oncologist to make sure that you do not harm yourself or allow your treatment to become less effective. Yes? So I notice the faces are like, okay. But, it's important for you to understand that God gives us all wisdom. Yes? And we have gone through many years of training for a reason, right? We want to be able, we all came into medicine to actually help persons. And we know our limitations. Yes? And at all times, our interest is actually trying to help you, trying to help our patients, not trying to harm them. And I'm only giving you the truth. I've seen persons who have used natural medicine and has harmed themselves. Why? They believe that they need to drink all of this because it is good, so they need to keep drinking it. And the thing is that they don't have an issue. But if you keep taking a herb for a particular thing because it's good and you don't have a problem, you eventually will cause harm to yourself. So your food is your first medicine. Outside of that, seek professional guidance in terms of what to take. And at all times, if you have a physician that doesn't like to listen to you about what you're taking, simply find another physician who would listen. Yes? It's best to find somebody you're comfortable with. Thank you.
I'm not Jamaican, right? But you know what I'm going to say? Talk it truth, doctor. Talk it truth. Talk it truth. That's what they say? Talk it truth. No, what they say? Talk what? Talk up the thing. And, we'll wake the song and tell the people. In Jesus' name. Amen. So now we're going to move on because we have a schedule, right? And we started late, rain, there was some myriad of things happening. But we're going to try and catch up. We're going to try and catch up because together we are stronger than cancer. So we are working together. So our next presenter is, we're talking about food nutrition. So we're bringing in everything. Bring it in. So we're going to have now Dr. Sabrina Palomino. Did I get it right? Sabrina Palomino, who is a MS Master's consultant dietitian at our public hospital and privately dietitian's corner and all of that. And she's going to talk to us about the do's and don'ts about nutrition during chemo cancer treatment. Do's and don'ts, nutritional management of patients with breast cancer. Let's welcome Dr. Palomino.
Good afternoon, everyone. It's a pleasure to be here to speak to you about nutrition. And I'm going to talk about nutrition management and some of the myths surrounding nutrition and in terms of what you can and cannot eat during breast cancer if you've been diagnosed. Now, it's important, I always say to persons, and all of my colleagues here would have alluded to it, is that nutrition is more a preventative medicine. So, we do encourage you to have proper nutrition from infancy, even from conception, it's very, very important. And you carry that throughout your lifestyle in terms of, getting the right balance in terms of the different nutrients that your body need. And it is more of a preventative measure. And once you've been diagnosed with any type of cancer, and now we're focusing on breast cancer, Nutrition is not going to cure it, but what nutrition will do is help with the management. So for example, if you're having certain side effects, there are nutritional management that you can use. And also it does help to build your immune system and, help in terms of your management and your outcome on certain therapies. All right, so we get into the nutritional management. I'll just ask my tech team if they can just move it to slide 5, and I'll begin from there. Thank you. So we know nutrition, and I always say that everybody has the basic knowledge of eating healthy, right? Right? We're introduced to it from basic school. We're introduced to Go Food, Grow Foods, and Glow Foods. But we tend to have that knowledge, but we tend not to set it into practice. Why? I don't know. But we all have that basic knowledge of nutrition. So basically, healthy eating is having a balanced diet, and this is especially important during breast cancer. And proper nutrition may help your body to heal from cancer treatment, which have numerous side effects, right? And depending on what therapy you might be experiencing, you might have some side effects such as mouth sores, low appetite, nausea, and vomiting. And these might affect your overall nutrition. So I'm going to discuss some nutritional tips in terms of managing some of these side effects that you might experience from your therapy. And then we're going to go into the debunking of some of the myths surrounding nutrition and cancer therapy. Next slide for me, please. So weight loss. So that is something that you might experience once you've been diagnosed. So what we do encourage you to do is that you have to eat small meals, small frequent meals. And the old saying, one cocoa full basket, right? So it's the same thing when you're trying to regain some weight if you have lost it during therapy or with diagnosis. We encourage you to eat small frequent meals, and these meals must be nutrient dense. What we mean by that is that whatever little that you're going to eat, it must have a balance of various nutrients. It should have some amount of carbohydrates that your body needs for energy, protein to help to build and repair those tissues and your muscles, and of course your vitamins and your minerals that are needed as your phytonutrients to help to build your immune system, as well as a little fat. Fat gets a lot of beating, right? But fat serves an important part in our diet, and especially if we're trying to increase our calories to help with our weight gain, you need to have some fat in your diet, but we encourage that you use healthier fats. So these are like your unsaturated fats or your monounsaturated fats, and these are usually your plant-based oils that we encourage you to have, and less of your animal fat. So, things with unsaturated, what we call saturated fats, like your meat fat, your processed meat, those kind of things. You reduce your intake of those. We also encourage you can use your supplements. And what I mean by supplements, we are speaking to what we call oral nutrition supplements. So these are usually liquid drinks that you might have. Because when we are losing weight, we tend to sometimes not eat, but we might drink. So there are many options out there. But of course, you have to consult your physicians and your dietitians to ensure that there's no drug or nutrient interaction that will happen with these supplements. You might experience some amount of nausea or vomiting. And we encourage, if this is happening to you, is that you try to avoid high fat or greasy or spicy foods, or even overly sweet foods, because these two can irritate and, cause the vomiting or the nausea to get worse. You can also avoid strong foods with strong odors. So sometimes foods like eggs or fish, they make you nauseous. So if you're experiencing some amount of nausea, you avoid these nauseous or these strong smelling foods. Sometimes a bland diet will work too as well. And basically a bland, soft diet is a diet that is not overly greasy or spicy, right? It might not look appealing to the eyes, right, but it helps in terms of, helping to combat this side effect of nausea and vomiting. And of course, we ask you to take more of a soft diet because it's easier to digest. And of course, these foods should be scheduled. We usually encourage you to schedule them on your treatment days, because sometimes after treatment, these side effects might be even more pronounced. And if you're experiencing sore throat, that's also a side effect. We do encourage you to avoid dry foods. Any food that might be coarse or rough in texture, and you try to eat more moist or soft foods such as your porridges, or if you're a fan of your smoothies, that is something you can have too as well. Or you can use your sauces or your gravies to add to your meals, and these will help to soften your meals and at the same time help to increase the calories if you're experiencing some amount of weight loss. We also encourage that you experiment maybe with your food temperatures. For example, some persons, if the food is cold, it might be irritable or it might be soothing. Sometimes it's warmth that is soothing. So you have to experiment with the temperature of your food to see if it's cold or the warm temperature that would be soothing to you. And then there's what we call your neutral diet. And I think Dr. Barnes would have alluded to this earlier in terms of, you have to ensure your immune system might be compromised because of the treatment that you're on. So you have to ensure that you wash your hands frequently. We all know about hand washing, right? We know how important it is. And especially during your cancer diagnosis or your treatment, before you eat, after you've finished preparing your meals, after using the bathroom, it's very important that you wash your hands. And you have to keep your kitchen surfaces and your utensils as clean, right, as possible as you can. We always encourage, for example, it might seem a bit tedious, but with this type of method is that you have separate in terms of your cutting boards. If you have one for your vegetables, you have one for your food from animals, and you try not to use like a wooden surface because with chopping, you'll have creases in there and you have bacteria that might deposit in there. So you try to have separate in terms of that. So you try to keep those as clean as possible. And of course, wash all your fruits. Where possible, you peel them because as you know, the skin is a protective layer and sometimes they can have dirt, they can have bacteria. And culturally, if a little animal bites a fruit, what we do? We'll cut it off and eat it, right? But no, we don't want that, right? We don't know what animal might have bitten that fruit. Yes, people cut it and have it, right? And a method that we use locally, we eating apples, what would we do? Bite the top and use it to rub the apples and clean it, right? So we encourage that you wash your fruits. That's something you don't practice, right? You wash your fruits and your vegetables. And if you can cook them, it's better to have them cooked than raw. Because by cooking, you would expose this bacteria to some amount of heat and it will have helped to destroy that bacteria. And when in doubt, throw it out, right? We always encourage that you don't eat old or moldy foods. So no cheese with no little mold on it. You cut it off and continue, right? The bread has that little mold. You just take out the slice that is moldy and continue. No, right? Once you're in doubt, you throw it out, right? So no old or moldy foods. Next slide for me, please. Next slide. All right, so let's talk about some myths. So it's myth busting time. What are some of the myths that you would have heard about nutrition and cancer? One of the major ones I start off is sugar feeds cancer. Right? We have heard that one, right? Now, remember, anything that we eat, our body is going to convert that to what? Right? Glucose, right? That's what our cells in our body use, right? And glucose is what? Sugars, right? So your body needs glucose. So it's not that there's no evidence showing that, except that sugar feeds the cancer cells. What we encourage persons to do is to stick to the recommendation in terms of sugars can be part of your healthy diet, but what we encourage you to do is stick to the recommendation. So for example, for women, it's no more than 6 teaspoons of added sugar per day, right? And what we mean by added sugars, this is sugars that are not naturally occurring in the foods that we eat. And these are sugars that we might add to our teas, to our porridges. So it's no more than 6 teaspoons of sugar per day for women. For men, it's 9 teaspoons. So you stick to your recommendations, right? And I always say to persons, just by turning around your food labels and looking at your nutrition facts, some of the times the things that we drink, just by having one bottle of those, we would have tripled or doubled the daily recommendation for sugars. And I always encourage, read your food labels. 4 grams of sugar is equal to 1 teaspoon. So you do the math. right? And look at your serving sizes too as well. Because you see serving size, half cup, servings per container, 2.5. And your nutrition facts speaks to what is in one serving. So if you consume that entire container, that means you'll be consuming 2.5 what the value is. So for example, if it has 10 grams of sugar and you drink that entire bottle, you'd have been consuming 25 grams of sugars, right? And the other myth is that processed foods can increase is not something that we encourage you to have when you're diagnosed with cancer. True. Processed foods, we encourage you to eliminate them as best as you can because they tend to have what we call, carcinogenic agents in them. So we do encourage you to eliminate or reduce your processed food. Another myth is that once you're diagnosed with cancer, you must have alkaline foods, right? And there's no evidence suggesting that whether you have alkaline or acidic foods, one is going to be superior to the other. What is important is that you try to have a balanced diet. But what we do encourage you to do is to have what we call a large amount or increase your intake of your phytonutrients. And what your phytonutrients are, these are naturally occurring chemicals that we find in our fruits and our vegetables. And these are shown to be advantageous in terms of they help to reduce inflammation in the body, they help to fight cancer cells. And you get your phytonutrients from your fruits and your vegetables. And we encourage you to eat a rainbow, eat a variety, because each color represents a different phytonutrients. So for example, your yellow vegetables, they will have flavonoids or carotenoids in them. And these are phytonutrients that are shown to help in terms of cancer cells, help to fight in terms of that, and to help to build your immune system as well. And red will have lycopene, which is shown to be very beneficial as well. So we do encourage you to eat a variety of foods, right, from all your 6 food groups and get as much colors into the body as possible because that will give you different types of nutrients and phytochemicals. So in conclusion, next slide, right? We do encourage that you let your food be your medicine and your medicine your food. We all eat. That is something we have in common. So when you do eat, I encourage that it be something that be healthy and nutritious and beneficial to the body. Thank you.
Thank you. Thank you very much. So how has it been so far? Online. I want to hear from my online people. If this is good and you're getting good, important information, put it in the chat. Put it in the chat. And also put your questions in the chat. We're going to soon come up to the question and answer segment of our evening. So now we're going to wind down. Now we're at the importance of screening and early detection. So I'm going to do that one. Yours truly, Dr. Daria Cornwall, consultant radiologist, head of the Women's Imaging Center at university, and also head of Health Ministries Director at this church. So I want us to get on now as we speak, and I know that time is essence, so I'm going to try to just catch it through. Can you, so we're going to look at what is screening. You're screened for this. Do your screening checks. What is screening? Can breast cancer be prevented? We're going to look at that. We're going to look at how to diagnose breast cancer early. We're going to look at why do you need a mammogram? Why a mammogram? Who should do a mammogram? How to prepare for a mammogram? And then we're going to bust some myths. So let's continue. So we're going to go through. Move down. We're not going to fluff again because I think the time for fluffing is done. Come down. So screening. Go back. So screening, put simply, is looking for disease in someone who does not have any signs or symptoms of that disease. So when we are all born, we all, at some point in our life, I'm going to take you through how disease happens. Most people are born without any disease. And children, there are some children with hole in the heart and different things. But when you are born and you're coming up, anything that is done before disease starts to prevent disease from happening is called a primary prevention method. So when you're children, you get your MMR and your polio and your DPT, and your measles, mumps, rubella, all those vaccines, and you eat healthy, and your parents tell you to eat up your vegetables, eat up, drink up your water, and you go and you exercise, and go outside and run up and down and play. All these things are primary prevention, right? Anything that is done, healthy lifestyle, before you get disease is a primary prevention. Vaccinations and immunizations and all of that, primary prevention. Exercise, primary prevention. Doing anything before a disease starts is a primary prevention method. So there are different levels of prevention. Now, at some point when disease starts, we don't know. So when a breast cancer starts, for example, no lump, the person don't have any lump yet, But breast cancer could come in the form of a lump. It could be a nipple discharge. It could be a rash on the nipple, like an eczema. Yes. It could be just a redness of the skin, a swelling of the breast, a lump under the arm. But early when the cancer starts, you don't have any of these symptoms or signs as yet. It's like getting pregnant. When someone is pregnant, initially you don't know, no morning sickness, no vomiting, no nothing. But if you do the urine test, you see pregnancy positive, don't it? Until now, after a while, now you start to see it show. So, and pregnancy is not a disease. But I'm using an analogy. Sickness, when it starts, we usually don't have any symptoms in the early phase, like when it's an early pregnancy. But pregnancy is not a disease. I'm just trying to make you understand. So catching the disease before it starts to show is what we want, if it is happening. And once you catch the disease before it starts to show, then you end up with getting early detection. Now, if you don't catch it before it shows and you wait for it to show, then what you are doing then is not really early detection, because by the time it starts show, like you have your lump, or like for prostate, you're passing blood in your urine or blood in your stool for colon or breast lump or anything like that, then you're really at a stage of clinical course, and any prevention method then is called tertiary prevention. You're really trying to prevent complications. So screening is a secondary preventive mechanism that is used to pick up disease, and I'm going to use the term show before it starts to show. You understand what I mean, right? Show. Next slide. Next slide. Next slide. So I'm not going to really go into how to prevent breast cancer. I'm not going to touch it too long in the interest of time. But we know that there are factors that we can control. We have modifiable risk factors. So there are some things that could help to promote breast cancer that we have control over. And there are some things that help to promote breast cancer that we have no control over. So let's talk about the ones we have control over. And the nutritionists talk about diet. Cutting back fat and getting your phytos and your colors of your vegetables and all of that. Very good. Nutritious diet is good. It helps also not just to put cancer-fighting things in your body and to boost your immunity and stuff, but it also helps you to get to your ideal body weight. And why we want people to be at ideal body weight is that with respect to breast cancer, fat in the body produces estrogen. And in some people, estrogen causes cancer. So, girls are made from sugar and spice and all that's nice, and boys are made from tadpoles and tails and stuff. So we have the estrogen that makes us sugar and spice and all that's nice, and the men have testosterone. So estrogen is really supposed to protect us. But in some women, and this is where the advancement in cancer care have come, we have learned over the years that this same estrogen that is supposed to be protecting your body turn around and be a traitor and let in cancer. It's like a security guard that let in thief in your property. Right? Then what are you going to do with a security guard? You're going to fire him? So we're going to show you how when we start to learn about the thief, the traitor now, we had a new set of therapy now to squash the traitor, fire the traitor. And that is one of the things that has revolutionized cancer management, firing the traitor. Before we knew about the traitor, we didn't know what to do. Okay? So you don't want fat in your body. You don't want excess estrogen in your body. And fat is one of the things that produce excess estrogen. So you want to get to your ideal body weight. Exercise helps to reduce weight and helps to build your immunity. Exercise in sunlight, because sunlight produces vitamin D in your skin, and that vitamin D helps to fight cancer. Simple. Helps to fight cancer. And vitamin D actually helps with over 300 metabolic processes in the body. So, and we find that black skin, even though we are in the sun, we are very resistant to the formation of vitamin D. Just like we are resistant to getting skin cancer because we have good stuff, good strong skin in it. Good. But that same good strong skin kind of prevents the formation of D. So a lot of black people, even though we're in the sun all day, our vitamin D level is low. So we encourage you, when you go to your doctor, ask your doctor to take the vitamin D. Check the vitamin D. It's a blood test that is done to see your D level. And if it is low, then you go on D3 supplements. Right? Breastfeeding also helps to fight or to prevent breast cancer, especially if you've breastfed for over 6 months or so, it helps. And of course, having pregnancy to term, a full term, a baby born, not a miscarriage at 3 months, but full-term pregnancy, taking a pregnancy to term before the age of 35 does help with some protection against breast cancer. Because what's happening with breastfeeding and pregnancy is that the hormonal levels of different hormones changes. And for example, estrogen will be a bit lower during these times. So you're kind of cutting back on the amount of estrogen that is circulating in your body during these times. Now, we're not going to tell you to go and get pregnant to try to prevent breast cancer, because we have enough women who have children who have breast cancer. Okay? So note that. And none of these factors by themselves is 100% effective. It's one cocoa add up and fill the basket. Right? Alcohol. We don't want that. And there's no safe level of alcohol. Any amount of alcohol you take in your body is your own risk. Okay? And smoking, of course. Next slide. So these are factors we have control over. Now, I know you know people who eat healthy, slim, don't drink alcohol, don't smoke, leader of them church and prayer warrior, pastor, deacon, no meat, and they come down with cancer. Have you ever known anybody like that? And then they say, wait, master, get cancer, and you know, eat meat, you know? Oh, look how she exercise. The thing is that there is benefit to doing the factors that you can control. Eating healthy and all of that does help. Because if someone comes down with cancer at 40 and they're leading a healthy lifestyle, bet your bottom dollar, if they weren't leading that healthy lifestyle, they will catch the cancer from 30. And if you catch it at 60 and you're leading a healthy lifestyle, if you weren't doing that, you might have caught it at 40. So eating and having a healthy lifestyle pushes off disease. Pushes off disease further. So if it's coming up the road to you, push it off. But there are some factors you have no control over. One of them is gender, being a woman, age, getting older. Those are two of the biggest risk factors for getting breast cancer. That's all you need. All you need to get breast cancer is be a woman and get older. Okay? And I'm sure that the opposite of getting older is to die young. Simple. Right? So if somebody was to say, okay, you know, if you're 20, you might say, boy, 20, I don't have to do none of these things they're talking about. Well, then stay at 20. But the only way to stay at 20 is to die at 20. So if you want to get the option, you say, God, let me live. Give me all my going for. Give me it. And I will just have to take care of myself and do all that I need to do. So give me the age. Give me it. Right? So we want you to know as you are getting the age that you take care of yourself. Right? So race. Even if you bleach, you're still black. And blacks have more aggressive breast cancer at an earlier age than their Caucasian counterpart. So we blacks tend to get more aggressive breast cancers than white. We get more aggressive. We get prostate cancers as well. So we blacks, even colon, we tend to get it younger. So we tend to get more aggressive cancers at an earlier age. And partly too because of our health-seeking behavior, we tend to die more from the cancers. Because, you know, we black people, we don't like go doctor. We don't want to go doctor. We don't want to do no checks. We're afraid of everything. And we're afraid of the wrong thing. Because best you go and get yourself checked. And I'll tell you why. If something is there, you catch it early. But being black is a risk factor for getting more aggressive breast cancer. And we don't have any control over that. Then now, the genes, the family you are born into. If you are born into a family that has the breast cancer genes, like Angelina Jolie, right? She, you know, I think she was on thing that said her aunt, there's a story, aunt had breast cancer, and with the genes, the BRCA1 and the BRCA2 genes. If you have any woman has the breast cancer genes in their family, you could turn up your pot and know it's just a matter of time, cancer is coming. But the truth is that it's only 15% of women have the breast cancer genes in their family or any genetic predisposition. 80% of women who get breast cancer simply get it because it's a woman getting older. That's all you need. Woman getting older. So then is breast cancer totally preventable? If you eat healthy, go to church, pray every day, eat the ideal body weight, you're the health star of the world, and you eat, you know, you don't eat this vegetable and you eat that and you cook everything and you eat your raws and you get your kale and everything. Does that mean that you cannot get breast cancer? No, because it's still a woman getting older. So all the factors that you have control over may prevent it from happening as as much as possible, but we're still getting older. Next slide. So if we can't prevent cancer, that means that God leave us to doom? No. I'm going to come to you to see, so what is the winning thing? If we are all on earth and getting older puts you at risk for cancer, then what we are going to do? What to do? Move on from that slide in the interest of time. That slide was just saying that both men and women can get breast cancer, just that women get it more often. Right? So 1 in every 8 women will get breast cancer in the USA. And so if there's 8 women in this church, 1 will get breast cancer. If there's 80 women, 10 will get breast cancer in the lifetime. In Jamaica, we actually say it's 1 in 21, but I think that's an understatement. It's about 1 in 11. So it is common. Breast cancer is common. And you see this lady with lump, move on from those quickly. I don't want to show those. You see these women with these lumps? And you'll say, why is Dr. Cornwall showing those ugly pictures? Next slide. I am at university. I'm doing my PhD. Oh, I just got my children into high school, and she passed GSAT and PEP, and everything is going fine. I just buy my house. I don't have no lump in my breast. I'm doing fine. Why show me them ugly pictures? Well, it's you I'm talking to. Your breasts are fine. You are fine. You don't have any cancer in your family, only little sugar and pressure in your family. Sugar, your grandmother died from old age. Well, it's you I'm talking to because you're a woman getting older. So what do? You get screened. And how do you screen for breast cancer? By doing a mammogram. A mammogram is an x-ray of the breast. Next slide. And that's a normal mammogram, 2 pictures of both breasts. We don't want you to wait on a lump. Next slide. That's a patient with early cancer. You see those little specks of salts like on the picture? That is how early cancer can start. When that patient came to us, she had no lump. She was just being obedient, and she heard that she must come and do she mammogram, and she came and did a mammogram. We found that. That's a very early stage of cancer. It's in situ cancer, and that's what the mammogram is good at. Picking up the cancers, if they are grains of salt, very, very early, while it's just grains of salt or calcifications. And 1/3 of cancers start by looking like this. And I'm telling you this, you cannot feel those salts in your breast. If you were to sprinkle some grain of salt in your breast and feel for it, you will not feel that because it is not enough, it's not a lump as yet. And these calcifications don't want you to do a mammogram because this cancer is a thief and it wants to sneak up. And you're going to say, boy, mommy, God, don't make sure you do a mammogram. Please, I want to take root and form lump. And so the calcifications are vexed with this presentation. They don't want me to do this. They want to wait until lump. And when you have lump, how the mammogram looks. Next slide. That's how the mammogram can look. By the time the lump is there, that cancer might have already started to spread. So we want you to do your mammogram while the breast still feel normal. While the breast still feels normal. Because if you don't do it while the breast feels normal, as a matter of fact, the mammogram can pick up lumps 2 to 3 years before the lump is felt. So you get a head start. When you do the mammogram, it picks up the lump 2 years before it starts to show. Understood? So we want you to do your mammogram. Move on. I'm just going to move forward. Move forward. Move forward. That's a patient with early cancer. That one before there. And I'm going to tell you quickly this story. This patient, we diagnosed her with cancer when it was like that. Little grains of salt. 1/3 of the cancer start like that. She went back to the clinic when we did the biopsy, and the doctor surgeon said, I have 2 good things for you, good news and bad news. Which one you want first? She said, give me the bad news first. Bad news is, you found a cancer in you, You found a cancer in your breast. So she said, so he said, you want the good news now? What good news you could give me? You tell me I have cancer. Then you want to give me good news. You're trying to mama guy me? I have sense. So he said to her, no, the good news is that we took out all of the cancer when we did the biopsy, the hook wire. So you don't need any surgery. You don't need to lose your breast. We tested it and we realized that estrogen is what causes your cancer. So we're going to give you something to cancel out all that estrogen in your body. Right? And so you don't need no surgery. So she came back over to me now in the hospital and she said, Doc, so they find the thing. This thing is the thing, And they tell me that I don't need no surgery. But she said, all the women wrong me need surgery. So I wonder if they're under-treating me. Listen to me now. Me are joking with them, I come here to get myself treated. So I want to make sure they're giving me the right treatment. And if I need surgery, let me get it. But this is the older woman. She's in her 50s. So I said to her, you have a good problem. We want everybody to catch their cancer early. And that is one of the jackpot to being stronger than cancer. Doing your checks so that if the teeth is in your breast, you catch it and lock the door and throw away the key. She has a sister who was about 2 years older than her. And she told her sister to go and get her mammogram. The sister said, you're lucky. I don't want to find out nothing. You go do your thing. To each his own. I'm not doing any mammogram. 5 years after she was diagnosed, her sister had come down with cancer. And by that time, now it was lump. She even had lump under her arm. And she had to get the whole radiation, chemo, and she's still not doing so well. While this other sister, now every year since she's had her thing, which is over 5 years now, she's been doing her mammogram and she's quite fine because we caught the cancer early, so we got rid of the cancer. Next one. Next slide. So I'm going to move out from that. When to begin doing a mammogram and how often? So when to begin screening and screening with the mammogram. Next slide. If you don't have any cancer in your family, you start at age 40. The reason why you're starting at age 40 is because your age becomes the problem. And it's a good problem. You're getting older, right? So the age becomes the reason why you are doing it, because your age now puts you at risk to gray hair, arthritis, forgetfulness, sugar, pressure, cancer, and all these things. Now the thief of cancer doesn't go to everybody's house. But it's only the thief know who house it's going, so everybody have to check the house. If no thief is there, we wouldn't find no thief. Simple. And every year you keep checking because you're 1 year older. And right now we are seeing so many cancers in 35 years old and 30s. Next slide. That we may suggest that you start your mammogram at 35 if you don't have cancer in your family. And if you have a normal one, then you could wait until 40, or you can start from 35 and go up, because we are seeing loads of women in their 30s with breast cancer. Next slide. You do it every year, once every year. Next slide. What age to stop? There's no age to stop doing a mammogram. Once you are in good health, where you could withstand the treatment, if we find the cancer, you can do your mammogram. I have patients in their 80s, 90s doing their mammograms. And we have found cancers in some of them, not all of them, because some of them will die from old age or some little sugar or pressure or something. Not all of them. We don't find it in everybody. We only find it in who have it. Okay? Next slide. How to prepare for a mammogram. Next slide. On the morning of your mammogram, do not wear any perfume, deodorant, lotion, or powder on your upper body or under your arm, because these things have little minerals in them, and they could show up on the skin and make us think it's little salt grain in the breast, little calcifications, and then confuse the picture. So walk with these in your bag and put them on at the end of the study, but don't put it on before, okay, in the morning. Next slide. Wear a two-piece outfit. It's always easier to take off a top than to take off a dress. But if it is that is a dress alone you have, go and get your mammogram in your dress, please. Next slide. Take your previous films with you. So if you used to go to this center in New York, and then you're now in Jamaica and you're here doing your mammograms now, get the CD or the images from New York and bring them, because we look at the previous one to pick up changes in the new one more quickly. It's eye training. Spot the difference. We spot difference is quicker when we have a previous. But we will look, if you don't have any previous, we still be good. Okay? Next slide. Now, there are some people who should start their mammogram before 40 or even 35. Because people who start at 35, 40 are people who don't have any cancer in their family. The only thing that is pushing this thing now is their age. Next slide. So if you have the breast cancer 1 or the breast cancer 2 genes, like I talked to you about the Angelina Jolie's before, having the breast cancer genes in your family, if you have the breast cancer genes, anybody in their family, you don't even have to test your own self. If it's in your family, then you know that cancer is coming, it's just when. So we start persons like that with the breast cancer genes in their family at age 30. So we advise all women, 30 years of age, when you reach 30, every woman is supposed to go to the doctor to get a risk assessment. The doc, tell me my situation. Doctor would ask you all sorts of things about your family history, if you have ovarian cancer in your family, also he will question you through. And then will also then check you and say, you need to start at 30 or you can wait until 35 or 40. Next slide. I'm almost done. Next slide. If you have more than one family with breast cancer diagnosed before the age of 50, like 36 and 37 and 40 and 41, that's a young age. If you have young cancer, people with breast cancer diagnosed early before 50 in your family, then you have to start your mammogram 10 years earlier than the age that that person got theirs. So if Mary Jane's sister had breast cancer at 37, and her mommy had breast cancer at 37 and 39, what age should Mary Jane start her mammogram? 27, 10 years earlier than the younger one. So I'm going to bust a couple myths and then I'm finished. Or we could actually go through the myths in the question and answer session. So we're going to bust the myths in the question and answer session. So this is the end of my presentation. Cancer is personal. A daughter, a mother, a sister, a wife, a church leader, a deacon, a deaconess, a cleaner, somebody who have no job, somebody who is the principal of the school, the prime minister. Cancer don't respect your pocket. Get screened. Once you reach 40, if you don't come from cancer family, get your mammogram done. And if you are from, check with your doctor at 30. If you're at increased risk, you may have to start your mammogram earlier. Thank you. So now, we're going to be going through some questions. So everybody have mic? So, first question. What is triple negative breast cancer?
So I spoke a little bit about it in my talk. We spoke about the different types of breast cancer, being whether you have estrogen-positive breast cancer, progesterone is another hormone that women have, and there is HER2, which is a type of protein that is on our cells. And you can have either hormone positive, which has the estrogen, or the progesterone, or both. And you can have HER2 positive, which has the protein HER2. If you don't have any of those three things, we say that you're triple negative. No estrogen, no progesterone, no HER2. Triple negative breast cancer is the least common type, so only about 10% of breast cancers are triple negative, but triple negative is very aggressive. And we tend to find that people who are diagnosed with breast cancer younger in age, or who generally find out that their breast cancer is late stage, very fast growing, often have triple negative breast cancer.
Okay. Next question. How long can you live with breast cancer?
So that question is a little bit difficult to answer, but we can try. Usually when we talk about these kinds of statistics, time frame and so on, we speak about it in terms of 5 years. So we have a statistic that says, what is the 5-year survival time of people with breast cancer? Generally, everyone who has breast cancer, if you're diagnosed today, in 5 years' time, 90% of people who were diagnosed are still alive. So after 5 years, 90% of the people who were diagnosed with breast cancer are still alive. But it varies by stage. If we find it at stage 1, then that number goes up to 95 to 99%. If we find it when it is locally advanced, meaning it is affecting your lymph nodes, that number goes down to about 85%. And then unfortunately, if it has spread, which is called stage 4 or metastatic breast cancer, only about a third of the women, or 30% of people who have stage 4 breast cancer, are alive after 5 years of being diagnosed. So it's very variable and it depends mostly on the stage.
So the next question. I have dense breasts. Why do I need to do a mammogram if I have dense breasts? Turn to the slide on the myth and I'll go to dense breasts. What do we mean by dense breasts? I'll answer that one. When we do your mammogram, we look to see how much glands you have that make milk. The more glands you have that make milk, that has an important implication. It increases your risk for getting breast cancer, apart from getting older. And the only thing that could tell us how much glands that make a woman have in her breast is the mammogram. Because the glands look white like milk on the mammogram. So the whiter the mammogram looks, that tells us how dense the breast is. You can move down to the midst, and I'll tell you when to stop. So when we look at it, your breast could either have plenty fat, plenty glands, or plenty fibrous tissue. The glands and the fibrous tissue looks white, while fat looks gray. Move down. Move down. Now the problem with the gland is this. This is the same question. Move to the next slide. You see that white breast? The white breast is the one that So at the top, you see the glands with it. So you basically, your breast is made up of like bunches of grapes. You have like 20 bunches of grapes in your breast, and each bunch has a main stem. So each grape makes milk, eats to the stem, and the main stem brings the milk to the nipple. And you have like 20 or so main stems coming to the nipple to bring the milk. Now, each of those grapes is what is called the glands, right? And that make the milk. And if you have a lot of that, your breast looks more white, right? And the more of that you have is the more the chance of cancer. So when we look now, you could either have a lot of fat in your breast, which is the first slide, doesn't have plenty white. Then you could have a little bit of white, which is the second slide, which is almost scattered. And the third slide, plenty white, which is called dense. Now we start to say dense. And the fourth slide is very dense. Next slide. Now, this is the same thing, showing you the breast, fatty with scattered glands, plenty glands, heterogeneously dense, extremely dense. Next slide. Now, the cancers, some cancers also look white like the glands. As a matter of fact, all the cancers on the mammogram look white. But some of them have the exact shade of white like the glands. And just like the soldier, when he's going into the armed bush, put on green clothes to camouflage. Well, the ones that look like the glands can camouflage and hide in the glands. So look at that C breast. Every breast, they have a cancer, you know. That white one have cancer up there. You could see the cancer in the fatty breast, the one with a little gland, which is B. D, are you seeing the cancer? You see it a little? D, are you seeing the cancer? So you could see why it started to blend in. Next slide. So what we do when you have dense breasts, we then add ultrasound to the package. Because on the ultrasound, the cancer looks dark. And that gives a contrast. So we could see this, we're still seeing white from the glands on ultrasound, but it looks dark. So some people say, why I have to why leave out the mammogram and do an ultrasound alone if I have to do ultrasound and mammogram because my breast dense? The reason why we can't do it is this. Next slide. Next slide. That's a dense breast. It's white. But are you seeing a different shade of white in some little grain that sands like in the breast? You seeing that? If we did not do that mammogram, we would not pick up those little grains of salt, those calcifications, that's a cancer there in that dense breast. It's a different shade of white to the glands, and it's only the mammogram that picks that up. Ultrasound cannot pick that up. So we have to do the mammogram even if the breast is dense. Okay? Next one. If I did chemotherapy and the lump disappeared, aren't I good? Why do I have to do surgery?
So the chemotherapy works quite well most of the time. Some of the time it does not. And we can have somebody who, if we're giving chemotherapy to try to shrink a lump in the breast, so we're giving it because it's maybe too big to safely remove with surgery, then we give the chemotherapy to try to shrink it so that you have a more successful surgery. When we give that chemotherapy, we know it's working by doing measurements of the lump in the breast or in the underarm. Sometimes it works so well that you can no longer feel the lump that is there. But you're just going based on feeling. Sometimes you can do a scan. The scan may or may not pick it up. If you are only going based on feeling or a scan, you don't know if there are cancer cells which are microscopic and cannot be seen with the naked eye, cannot be seen with an X-ray. We don't know if they're still there. And so not doing surgery to remove the area that the lump was will then allow, if there are any microscopic cancer cells left, they can then grow back when the effects of the chemotherapy are out of your system. And it's something that you can see quite often happen. So it is always best to go ahead and get the surgery done because any remaining cancer will just grow back when the chemotherapy is out of your system.
Okay, answered, question answered. Okay, next question. Is there any place in Jamaica that you can test for the genes for breast cancer?
So there are places that will take the sample. We don't have labs in Jamaica that do the breast cancer testing. So the Angelina Jolie gene, the BRCA gene, we can take the sample here. Most of the time it's a saliva test. Sometimes you can do a blood test, but we have to send them abroad, unfortunately.
So where in Jamaica can you go to get that saliva test sample taken?
So there are some oncologist offices that offer it. I know of 2 that do it right now. And then also there are some companies that make the medication that is used to treat some of these kinds of breast cancer, and they do that testing for free because I suppose they're thinking, well, if you know that you have it, then maybe you can get this medication. So most of the time, an oncologist office will be able to point you toward getting the BRCA gene testing.
Okay. Next question. I had stage 1 breast cancer. I had a lumpectomy. My concern is that the cancer will return. Or will it return, or can it return?
So it's possible. I don't know. We need some more details. So for example, a lumpectomy perhaps is a good treatment option for somebody that has a very small tumor. So I would have to know the size of the lump. I would have to know whether or not there were lymph nodes checked for, if lymph nodes were there. And I also have to know the type of the breast cancer. So there are some additional things that might need to be done. Do you need hormone blocking medication? Do you need additional treatment? Those things would all depend on the stage of the breast cancer, the size of the lump, as well as the type, if it is hormone positive, triple negative, or has HER2.
Okay, thank you. I'm going to come back to that. What is the importance of mental health during and after diagnosis and treatment? Dr. Green.
Mental health is massively important. There is a new body of evidence that shows that if you're emotionally unwell during cancer treatment, there are releases of, the body releases stress hormones that actually amplify or negate the effect that the treatment is supposed to effect. It also causes, maybe on a less complicated level, the increase in your heart rate. And when your heart rate increases, that also increases your circulatory drive. And if your circulatory drive is increased, that increases your risk of spreading the cancer to other sites in your body. So someone who is emotionally or psychologically distressed should be referred to see a mental health or a palliative care doctor because it is to their benefit.
Thank you. Didn't know that, right? Time. Oh, any question from the in-house? Come to the mic. Come to the mic. We're going to take your question. We are wrapping up now, kind of. Come to the mic. Come to the mic, please. NHF. Does NHF cover medication used to treat breast cancer?
So yes, an NHF card does cover a whole lot of the medications that we use in treatment, some chemotherapy, some medications to treat symptoms like nausea if you're on treatment or pain. And if you're at a public hospital, most of those medications are available free of cost. There are some newer medications that are not covered, but I would say the basics are.
Oh, thank you. Next question. Yes. Yes, take the mic to Soldier because he can't. While Soldier is coming, the next question is, if you requested to do a biopsy, will you be required to repeat that biopsy every year? Hold on, Soldier, I'll just answer this quickly. If a biopsy is normal or negative, that result, we don't need to repeat the biopsy every year on you if that biopsy is negative. If it is cancer, we don't need to repeat the biopsy, we need to treat the cancer.
Yeah. Doc, watching on the TV the other night, I never know a man can have breast cancer.
Yes.
So, may I say to somebody, At the same time, him say, soldier, what kind of madness that? I said, no, I'm a doctor, my godmother. She know what she has said. So me ask you now, saying the man can have breast cancer. You say it, you know, that man can have it too.
Yes, I did. So I'm saying it again. Men can get breast cancer. You finished, Oldie?
Yes,
okay,
ma'am.
so okay. Men can get breast cancer, but it's much less common. So in Jamaica, or generally, let's say 1 in every 8 women in the US or so in Jamaica will get breast cancer. For men, it's 1 in every 3,000 men. So it's much less common, but here it is. You think it's 1 in every 3,000 men, but I know at least 6 men who are that 3,000 man. And to that man, he is not 3,000, him is him. Right? So we encourage men. So what is the difference between men and women? We encourage men, just like we encourage teenage girls and men going right through. Check yourself. Watch your breast. Check yourself. Boys, girls, teenagers coming up. If you feel anything in your chest at any point in time in your life, go and check it out with a doctor. Do not ignore any lump or any change in your breast. That is for men. And you do that for the rest of your life. For a woman, you start doing your breast examination right through. You do your breast examination from teenage coming up. Every month after the period and menstrual period. And if you feel anything, any changes, get that checked right through until you die. The difference now is that when a woman reaches the age to do the mammogram, even if the breast feel normal, when you reach 40, if you don't come from cancer family, even if the breast feel normal and you're on top of the world looking down at creation, take the normal breast to the mammogram place, get a mammogram done to make sure the breast normal for truth, and then you take the breast back home. So every year your breast should get an outing. That's for the women who are 40 years and over. And if you have the breast cancer genes in your family or the increased risk of breast cancer, like people early in your family have that, or even ovarian cancer, then your outing needs to be earlier than 40. Okay? So,
okay, all right. I've heard, I'm not sure if it was mentioned, but the points were made about some of the points that things that can be done in terms of the diet and so on. But there are 2 factors that I'm looking at, and maybe you could elaborate or say what is the correlation with cancer, breast cancer. Managing stress, and rest.
Thank you for that question. I think you may have entered the session a little late because that was the first thing that was addressed. So I will tell you, as a palliative care doctor, when my patients sit in front of me, anecdotally, they say to me, "Doc, is stress cause it?" I have not met a patient who hasn't looked me in the eye and advised me personally to live a balanced life. That's number 1. On a scientific level, stress comes in different forms, and stress is a normal reaction to whether some external, environmental, or internal perturbation. So something that upsets the balance. Now, distress is the medical term that we use to qualify severe or prolonged stress. So when stress is severe or prolonged, it sets in motion some inflammatory reactions that can, in effect, change the genetic structure. And cancer is a genetic disease. At the genetic level, these changes, if they are not, it is a prolonged state. So these genetic changes accumulate and will eventually present itself as a malignancy or cancer. So I hope that answers your question. That's the correlation that science is no supporting.
Okay, one last question here, and then we have one question in the chat.
All right, quickly. I am, I guess, representing the early screeners because I have it. I mean, I haven't tested for the gene, but I have it very close. I have an aunt who died of breast cancer that had metastasized and all kinds of excitement there. So I started my mammograms early. Just wanted to know, in terms of, I've seen and heard, people talk about the fact that, like when I go to do the mammogram, they set you up and then the person who is pressing the equipment, they stand behind a screen. I just wanted to know, as a individual doing a mammogram, that exposure, does that increase my risk? Because I've heard it, I don't subscribe to it because I do my mammograms every year, but just wanted to know if there is any thoughts on that.
Okay, very good question. So she's asking whether doing a mammogram exposes you to so much radiation that it could cause harm or cancer. Now, the amount of radiation you get when you do a mammogram is equivalent to the amount of radiation you would have gotten from just living on Earth for the last 3 months, background radiation. So while we are here now, you exposed to radiation and you don't know, background radiation, right, just from living on Earth. So if that radiation dose that you got for the last 3 months from just going up and down and being around the hot place is what you get when you do a mammogram, and that were to kill you, then all of us would be dead. Because you have each year have 12 months. You have 4 3 months. So that is 4 sets of radiation equivalent for a mammogram. And then you have, if you're 2 years old, that is 8, 4, So the amount of radiation you get for a mammogram is equivalent to 3 months a dose of rest living on Earth. Additionally, and that wouldn't kill you, additionally, put a different way, the amount of radiation you're exposed to when you do a mammogram is equivalent to the radiation you got if you took a trip to New York or Italy or France or Jamaica or Trinidad and back. When the plane goes up in the air becomes rarer and you're exposed to ionizing radiation in the air as the plane goes up, and that's a fact. The radiation you get when you do a mammogram is equivalent to the dose you got when you took a round trip. So you go to New York and come back, that radiation is what you get when you are doing a mammogram. So basically, if everybody was to, I'm sure many people have taken trips. When you go to do a mammogram, it's like taking a trip. Because that one trip will not cause cancer. Okay? And you're doing one mammogram every year. Okay? Thank you. So one last question, I think I saw it in the chat. Then we close off. Yes, you're going to address it, Justin.
Well, let me quickly address sleep. So anything that goes against the grain of how we were beautifully designed causes a stress response. So if you're hungry for long, so if you're in a point of chronic starvation because of poor eating, poor nutrition, if you're at a point of chronic sleep deprivation, maybe because you're a workaholic, you work at night. If you are lonely, because we're not designed to be lonely, that triggers a stress response. And if that is severe or prolonged, and I must say that the research is finding that stress to the neonate can cause genetic changes in the baby. So just to combine everything, you may ask me, so what if you're constipated for long? We're not designed to be constipated, because if we're eating well, we'd be evacuating daily. So anything that goes against the grain of how God created us to function causes a stress response. And if that is severe or prolonged, then the end result can be cancer.
Okay, thank you. Next question. Does hormone replacement therapy cause breast cancer? And while Dr. Barnes is coming on to answer that, someone wanted to know the places that you can do the genetic testing. It can be done at Cunningham Medical Center near the stadium, National Stadium, Cunningham Avenue in Roosevelt. Or you can Google it, Cunningham Medical Center or Island Medical Specialist Medical Center on Beverly Glades in Beverly Hills. So those two centers do the genetic testing. So doctor, hormone replacement therapy.
Yes, so it is thought that hormone replacement therapy that people take to help to alleviate the symptoms of menopause, because what it's doing is basically giving you extra estrogen, can increase your risk of breast cancer. So that is one of the risk factors that we found in people who develop especially hormone-positive breast cancer. So yes, there is not as much information on something like taking the birth control pill or injection, but definitely hormone replacement therapy has been found to do it.
Thank you. Next question. Is there something other than, the last question, other than mammogram that can be used to diagnose breast cancer early? Now, there's something called tomography, where they check for the heat in the breast. Lots of people propose that tomography can catch cancer early. Tomography cannot do that. It is not scientifically proven. Because they say that cancer produces heat and you could use a thermogram to pick up the hot spots in the breast. There's no scientific proof that that catches cancer early. What we know catches cancer early is the mammogram. Okay? Thank you. So, it has been an evening, hasn't it? I want to thank you, the audience, for coming through. I want to thank you on YouTube for listening in and being so participative. Our YouTube is lighting up. Thank you, thank you, thank you. And sticking with us to this almost end. We're not done yet, we're going to have Vespers. But I want to also thank all the ladies, all our presenters, our panelists who have taken the time off from their otherwise schedule to be even to be in hospital. They've taken the time off to be here with us, and that's a lot of effort and energy, and we thank you. We thank you. We thank you. And we also thank you for all that you are doing in the fight against breast cancer and the excellent service that you provide to all the folks in Jamaica land we love. And I know your reach is international, so it's not just Jamaicans you treat everybody, and we thank you. We thank you. We thank you. We're going to hand over now to our Vespers, and our Vespers will be done by another medical doctor, a pediatric surgeon, and an elder at the Andrews Memorial Seventh-day Adventist Church, Dr. Noel McLennan.
Thank you so much, Dr. Cornwall. Very good evening, church. I will not be long. You can say good evening. Sabbath is over, so it's just time to tidy up everything. I must also say thank you to Dr. Cornwall as well as the panelists of experts who have educated us so well this evening. Ordinarily, presentations of this magnitude would attract a significant fee just for showing up and giving this kind of information if it was to be done in certain other forum. But we have gotten it here, and we thank you. I just want to extend my own gratitude to you. Thank you for adding to the body of knowledge, both here locally in our congregation as well as those online. Gentlemen, we do have a responsibility as well, notwithstanding the rarity of the condition in men, but we still have a responsibility to check ourselves as well as support the women in our lives, whoever that woman happened to be. Wives, sisters, mothers, grandmothers, it doesn't matter. Aunts, friends, co-workers, doesn't matter. We have that great responsibility. And it is with that in mind that I will quickly tidy this all up. It is a day well spent. The Bible did say, and does say, in 3 John, it has only one chapter, so 3 John verse 2. Beloved, I wish above all things that thou mayest prosper and be in health, even as thy soul prospereth. So God does have a great interest and stake in our own health and our own well-being. And I will not be long. I intend not to be long. duly noted. This is what Paul has reminded us and admonished us in Romans chapter 8 and verse 37 down. Nay, verse 36 down. As it is written, for thy sake we are killed all the day long. We are accounted as sheep for the slaughter. Nay, in all these things we are more than conquerors through him that loved us. And in the context of what we had just heard, and the psychological state that an affected person may be going through, as well as that person's family and support system, the verse here is saying, for I am persuaded that neither death nor life, nor angels, nor principalities, nor powers, nor things present, nor things to come, nor height, nor depth, nor any other creature. And we could easily extend this verse, nor breast cancer, and all that comes with breast cancer, shall be able to separate us from the love of God, which is in Christ Jesus. That's the thought I would like to leave with us this evening as we contemplate on all that we have heard and all that we have been meditating on and thinking about, and as we face another untried week to come. Just getting older puts us, yes, the focus this evening was on breast cancer, but just getting older puts us at risk. Age is a risk factor for practically any cancer. In my own practice, thankfully, I don't see breast cancers in children. I just don't. And it is actually a good thing. Children have enough to deal with. But as a general practitioner, a practitioner in the field, I still have to have a keen eye, because the children do not turn up to us by themselves. They turn up with their mothers mostly. Matter of fact, when we do see a father, we are quite encouraged. There's another story to that, but I won't go into it. But the fact is that we have to be keen just enough for the parents and the guardians who turn up with these little ones as much as we are for the children. And so, as I close, the question comes from the songwriter. Does Jesus care when my heart is pained too deeply for mirth and song? Hymn 181 in the New Hymnal. As the burdens press and the cares distress and the way grows weary and long. We're going to sing this song to close, and then we will say a word of prayer, after which we will have the certificates being handed out by the fire marshal. And I will reserve the other announcement until after I pray, just to keep the thought. Let us still sing to close off this thought. Does Jesus care? It will be led out. 181 from your new hymn.
Let's all stand. We'll sing the first and the last stanzas. Does Jesus care when my heart is pained too deeply for mirth and song? As the burdens press and the cares distress, and the way grows weary and long. Oh, yes, he cares. I know he cares. His heart is touched with my grief. When the days are weary, the long nights dreary, I know my Savior cares. Last stanzas. Does Jesus care when I've said goodbye to the dearest on earth to me? And my sad heart aches till it nearly breaks. Is it all to him does he see? Oh, yes, he cares. I know he cares. His heart is touched with my grief. When the days are weary, the long nights dreary, I know my Savior cares.
Amen. Let us pray. Oh Lord and our Father in heaven, we thank you, Lord, that you have reminded us that you care. Please help us to embrace this fact, even as we go in this new week. Regardless of our challenges, Lord, it could be something as serious as cancer, or it could be something else. Maybe minor to some people, but major, depending on the individual. Whatever the situation, Lord, Father, remind us that you do care. And we can cast all our cares upon you because you care for us. Thank you, dear Lord, for your everlasting love. We ask for your divine protection over us this week on the busy roads, in our homes, at our workplaces, in our interactions with our family members, our neighbors, our co-workers, everyone. Father, may you direct our interactions, our conversation. May the words be seasoned with your love and with grace. And may we remember that soft answers turn it away wrath. Father, we ask that you may bless us and keep us. Thank you for hearing and answering our prayers. For we pray in Jesus' precious name. Amen. Amen. Just going to ask you, please, to sit for a little while, and we just move right over into the next quick exercise. While that is, they are making arrangements to do that. From the Children's Ministry Department, you are being informed that food and soup are on sale on the outside when we are all finished inside here, so we can support the Children's Ministry Department by purchasing food and soup. Warm soup in the cool weather. I now turn over to Brother Yannick.
Good evening, church. I know you have had a very informative session. Promise I'll be short. All right, so for this program, we intend to acknowledge our officers who have participated in a safety monitor fire warden training a few months ago. Testing, hear me better now? All right, so I was saying that for this session, we'll be acknowledging the officers who have participated in a fire warden safety monitor training. As I said, I intend to be short, so to release you to go home. All right, so we open with a short prayer. Father in heaven, we give you thanks for another day. We give you thanks for life. We give you thanks for learning, dear Lord. We ask, dear Lord, that the program will go towards your glory and for the protection of the church. Amen. All right, so I have a little speech. Good evening, everyone. It's a pleasure to welcome you all here today as we gather to celebrate a remarkable group of individuals who have taken on a vital role in our church as fire wardens and safety monitors. The purpose of today's ceremony is to honor the commitment and dedication of those who have completed specialized training led by the representative from the Fire Prevention Unit of the Jamaica Fire Brigade. This training was designed to equip our church officers with the skills and knowledge needed to act quickly and effectively in the event of a fire or emergency, to protect not only themselves but everyone around them. As fire wardens and safety monitors, their role is to promote a safe environment by recognizing fire hazards, understanding evacuation procedures, and assisting during emergencies. They are our first line of response, helping to ensure that we're always prepared and that everyone stays safe in times of crisis. Please join me in expressing our gratitude to these dedicated individuals and to our trainer from the Jamaica Fire Brigade, Sergeant Dwight Tinglin, for empowering our church with this life-saving knowledge. Let's now proceed with the program as we acknowledge the achievements of our newly certified fire wardens and safety monitors. I will hand over to Sergeant Dwight Tinglin. Where did Sarge go? All right, so while he's on his way, Dwight will give a little brief remark about the program that we had done a few months ago, and then I'll hand over to Kevin, who will call the names for the issuing of the certificate. Yes. A little round of applause for Sarge for me, please.
All right, good evening, Andrews. All right, we'll spend in the house of the Lord today, right? All right, so who won't belong? So, on behalf of the Jamaica Fire Brigade, we deem it as an esteemed privilege to be here this evening. We're happy that you saw the need to have members of the church to be trained as fire wardens, as you have recognized the vast importance of being fire safe. We need more churches to emulate your initiative as having basic understanding of first aid, firefighting apparatus is the difference between saving critical materials, and I recognize that you have a number of electronics here, right? And furnitures, right? And saving critical materials and furniture and preventing them from watching them go up in the unforgivable flames. So again, I want to applaud the Andrews Seventh-day Adventist Church for taking this initiative, and we hope that others will be trained as well, right? So Mr. Yannick, the task with that responsibility, feel free to call us, right? Because we do recognize that the quicker, or what we say in the fire service is that we want to knock out the fire in the incipient stages, right? Because what we recognize is that there are different stages of the fire. And if we allow the fire to get too hot, it will basically engulf the entire building in no time, right? And the training will tell you all of this, right? So I don't want to give you too much information, right? At this time, because, you know, it's a well-spent day. But we have an entire training program dedicated to give you all the vital information that is critical, right? And if you have other organizations, if you're part of any other organizations, we can sure be there to pass information, as well as a very exciting, practical. Mr. Yanni could have told you that it's a pity to have the videos for sure right now. But it's a very good program, right? And it's very essential for each and every Jamaican. So again, thank you for signing up and having your participants and the members of your church trained. Thank you.
Okay, good evening again. So, no man, I think you should come on this side because I'll be giving you the certificates. As I call the names, I want each individual, as you hear your name, to come up so you can be presented with your certificate. All right, the first person I have here is Amru Leila. I don't see her. Anastasia Johns. Okay, Andrea Parker. I don't see her. Okay. Audrey Carodas. Alzi Downs. Cecile Cooper. Cecile Taylor. Shavendo Carodas. Dorothy Bailey Smith. And I hope I pronounced this properly. Hadia Jones. Is that the right pronunciation? Jessette Hamilton Morgan. Jessette? Okay. Joel Montague. Karen Winter Robinson. Loy Lawrence. I remember the video with Sister Loy. Michael Vanzi. Nikki and Bent. Opal Reed. Paulina Ritgard. Raymond Cooper, Suzette Clacken, Sonia Dixon, Tamazina Dunbar, Praveen Little, Yannick Jolly Stone, Ivan Gunning. That's it. Congratulations to all those who have been certified. Yes.
All right, so once again, congratulations to all the participants. And the preparation is all about God's business, right? God has entrusted unto us many things, right? Our church, the appliances that we have inside the church. And it's very imperative that we are good stewards, right? And being trained to mitigate against any situation that might arise is very good, right? God says, I wish above all things what? That we what? Prosper and be in good health, right? And this can apply to the prosperity of the church. And if we can ensure that we can have proper mechanisms in place to protect what God has given us, then indeed we are following the Bible. So again, I want to implore each and every one of us, not only at church, but even in your own homes, right? Ensure that you have these first aid devices. They are fire alarms, very critical, right? We know the fire brigade do not come to your homes and inspect and ensure that you have these fire alarms there, but it's for your own benefit. When you are in a deep sleep, especially 2 o'clock in the mornings, and by the way, that's the time when we tend to get most of our calls, right? 2 o'clock in the morning, you hear the bell go off, house on fire, house is on fire, right? Persons are deep in sleep at that time. The smoke there, the fire is raging, but you're deep in sleep. So these alarm systems will wake you up and alert you. So it's a good investment to get these devices. We also encourage persons as well, not going to take too long, to also invest in fire extinguishers, right? They have many extinguishers, different weights and all of that, right? And there are different types, as the training tells you about. We could get one most appropriate for our homes, right? Because we work hard. God bless us with jobs that we can work hard and buy homes and buy things put inside our homes. So as a result of that, we should have the necessary equipment to protect them, right? Yes, we ask for God's protection, definitely, right? But at the same time, God has entrusted unto us our brain to think. He has entrusted persons the capacity to build these items that we can protect our appliances and our homes, right? So, again, I'm imploring each and every one of us to invest in our homes. But what is even greater is of your own self. I quoted the scripture earlier that God wishes above all things that we may prosper and be in good health. So while we are taking care of the appliances at home, let's ensure, this is outside the fire brigade, and I always do this, ensure that you get plenty rest. Eat healthy, right? Sometimes we sacrifice the laws of health, the 10 laws of health. Sometimes we're good for all 9, you know, and we preach sometimes the 10 commandments and say, remember the Sabbath day to keep it holy. And sometimes we forget the other 9, right? No, the laws of health implores us to get good sunlight, balanced diet, right? Rest, water, right? But somewhere down the line, sometimes, most of us, all of us, might fall short on one aspect of these 10 laws of health. But as much as possible, I'm encouraging you to take care of your own body temple, right? Because guess what? Your bodies are what? The temple of the Lord, right? So before you can think about taking care of anything else, the church or your home, your body is a temple of God. And as we are celebrating, I don't think we should celebrate it today, but we call it celebrating nevertheless. Breast cancer awareness, right? Let as much as possible, ease off of too much of the sugar. Yes, the sugar is a killer, right? I'm not going to say we're not going to go totally off sugar because we need the sugar. It's a part of having a balanced diet. But the amount of sodas that we're consuming, the time when we eat after 5 o'clock, right? The body don't have time to break down all these sugary stuff, right? We have to take our health seriously. Meditate, read the scripture, read the Bible, meditate upon the word of God. Because you go to many of these hospitals and persons are getting all sorts of anxiety attacks and all these things. Right? This never happened back then when our forefathers never have all these cell phones and they're so addicted to the cell phones. Right? Let us try to focus and meditate on God and be as best citizens of the kingdom of heaven. May God bless you and do enjoy the rest of your evening.
All right. So thank you, everyone, for your patience and your participation. It's truly appreciated. And have a wonderful rest of the week until we meet again. Oh, Elder, are there any announcements? All right, no announcements. So thank you very much. Oh, there is